Hello, thank you so much for watching my video introducing my HAI Epi competition proposal, Association of Sociodemographic Variables and Neonatal Hospital-Onset Bacteremia in a National Cohort. My name is Erica Prochaska. I am a third-year Pediatric Infectious Diseases Fellow at Johns Hopkins University, and my primary mentor is Dr. Erin Millstone. Neonatal hospital-onset bacteremia is important to study because it's highly morbid. It is associated with high mortality and an increased length of stay. Hospital-onset bacteremia is an easier metric to report than central line-associated bloodstream infection, or CLABSI, and therefore is a planned future CDC quality metric. There are long-standing neonatal mortality disparities in the United States, highlighted here. This is 2017 data. Dark green are neonatal deaths. You can see that there are stark gaps between white, Black, American, Indian, and Alaskan Native mortality, as well between white and Native Hawaiian or other Pacific Islander and Hispanic mortality as well. We are starting to understand the contribution of healthcare-associated infection disparities to neonatal mortality. There are higher rates of late onset sepsis in Black and Latino Hispanic neonates as compared to white neonates, and Black and Latino Hispanic women were shown to be more likely to deliver at hospitals with higher HAI rates in the state of California. For preliminary data, I performed a sub-analysis of a previously published cohort from Dr. Millstone's research, which showed that within 3 Johns Hopkins Hospital NICUs, there was a higher crude incident rate ratio of hospital-onset bacteremia between non-white to white neonates weighing greater than 1,500 grams. This showed us that we needed to explore whether this was represented in national data. The specific aim that I'm proposing is to estimate the national rate of neonatal hospital-onset bacteremia, or HOB, and measure the independent association of sociodemographic variables on the rate of HOB after adjusting for chronologic age, birth weight, and presence of a central venous catheter. The cohort that I will be utilizing is a multi-center retrospective cohort comprised of 320 hospitals in the United States, of infants admitted between July 2016 and 2021, and HOB will be defined as a blood culture positive for fungi or bacteria day 4 or greater of admission. Only infants admitted for more days will be included, and only 1 HOB event will be counted per patient. I will be utilizing a Poisson regression model to estimate the daily risk of HOB, adjusting for birth weight, central venous catheter presence, and postnatal age a priori, and then extending the model to look at additional variables, both clinical and sociodemographic, and then in a file model, including all sociodemographic variables with variance inflation factors. I will then conduct a subcohort analysis, pulling out from the cohort different sociodemographic groups in order to identify within sociodemographic groups where are there risk factors for hospital-onset bacteremia, such as type of NICU at which a child is delivered or state in which they are delivered. Future directions for the study include identifying areas for infection prevention interventions to address found disparities, including qualitative methods to identify drivers of inequities, building upon my current interviews with NICU parents on infection prevention, understanding, and implementation. We could also estimate rates of bacteremia-associated mortality. However, we would need to use a subset of NICUs, as some NICUs included in this cohort have a high transfer out rate. I also want to take a moment to acknowledge that the drivers of health inequities are complex. This is an adaptation of the social ecological model. It shows that there's many different levels that contribute to an individual's risk of disease. For my future research, I plan to be focusing on the institutional interpersonal level, again, acknowledging that there are many drivers that need to be addressed in order to narrow the gap in health disparities in the United States. For my budget, I am proposing a salary for a research coordinator and an analyst. I'd like to thank my research team, my primary mentor, Dr. Erin Millstone, who has extensive experience mentoring trainees and junior faculty in infection prevention methods and research, Dr. Deidre Cruz, Professor of Medicine and Deputy Director of the Johns Hopkins Center for Health Equity, who's mentoring me in health equity methods, and Dr. Julia Johnson and Dr. Renee Boss, who are both neonatologists. Dr. Johnson is an expert in infection prevention and clinical epidemiology, and Dr. Boss is an expert in qualitative methods, particularly in the NICU. I would also like to thank the Millstone research team that has extensive experience in longitudinal and multiple center analyses and are mentoring me as well in how to design and carry out this study. And I'd like to thank the CDC Epicenter Collaborative and funding from the Centers for Disease Control and Prevention. And thank you very much, and I look forward to seeing you at HAI.